Knock knock, hi, I'm the new med student. Hey, check this out. It's the platysma muscle. Yeah, that's cool. It's the only muscle dedicated to expressing secondhand embarrassment. You must really like anatomy. Oh, I love anatomy. What specialty do you want to go into? I'm thinking about ophthalmology. Why? I don't know, eyes are kind of cool, I like the surgeries. Ophthalmologists think they're so great just because they get a bunch of cranial nerves. Well, look at this, huh? Look at that. Cranial nerve 11. Do that. Backing out of your driveway would be a nightmare. Yeah, but without the optic nerve, you wouldn't be able to see to drive. Well, welcome to E.N.T. Let me introduce you to your enemy for the next 4 weeks. A Q-tip? It's the second most common cause of hearing loss among people who think a spider crawled into their ear while they were sleeping. What's the most common cause? A spider crawling into your ear while you're sleeping. Oh my god. Alright, let's go down to the ED and show some grown-ass doctors how to stop a nosebleed.
Hello viewers, today we will talk about that one topic of ENT that every doctor is aware of and that every doctor must have some interest in. Today we will talk about epistaxis, which is just a fancy medical way of saying bleeding from nose. If you are someone who wants to find out how to tackle bleeding from nose, or you are an MBBS student wanting to know the right approach to treating a patient with bleeding from nose, then this video is perfect for you. So without further ado, let's get into it. Epistaxis, as I said, is a term to describe bleeding from nose. I believe that doctors developed a secret language to communicate with each other without patients understanding what they are talking about. That is why we have terms like epistaxis, and one of the common causes of epistaxis is idiopathic, which is just a fancy way of saying we don't know what is causing the epistaxis. Now, of course, epistaxis also has some local causes and some general causes. Local cause means the cause is in the nose or in the nasopharynx. Now, in the nose, epistaxis can be due to trauma, which may be a blow to the nose, maybe fingernail trauma, which is of course the common cause of bleeding in children, and it can also be a base of skull fracture, especially anterior cranial fossa. Also, middle cranial fossa fracture can cause epistaxis, although it is typically associated with bleeding from ear, but there is a connection between the middle ear and the nasopharynx, that is the eustachian tube. So middle cranial fossa fractures can present with otorhinorrhea. Moving on from traumatic causes of epistaxis, there can also be infectious causes of epistaxis. It can be an acute infection or a chronic infection. Acute infection can be viral rhinitis, or it can be chronic infection like tuberculosis. Foreign body in the nose can also cause epistaxis. The foreign body can be a non-living foreign body where you can just use your imagination, or it can be a living foreign body like maggots and leeches. Of course, if a non-living foreign body is left in the nose untreated, then it can result in stone formation, which is known as rhinolith. Rhino means nose, lith means stone. Other local causes of epistaxis can be neoplasm, such as a benign tumor in the nose like hemangioma or papilloma, or a malignant tumor in the nose like adenocarcinoma or any other carcinoma, any other cancer basically. Atmospheric changes can also result in epistaxis. High altitude or coming up to the surface after a deep sea dive can lead to bleeding from nose. Also, deviated nasal septum can result in epistaxis. Moving to the general causes, hypertension is controversially associated with epistaxis. Nobody knows if epistaxis causes hypertension or hypertension causes epistaxis, but it is believed to be one of the contributing causes of bleeding from nose. Bleeding disorders certainly can present with bleeding from nose, like aplastic anemia or hemophilia or von Willebrand factor deficiency. Certainly, people taking blood thinners or anticoagulant therapy are more prone to episodes of profuse epistaxis, because once the bleeding starts, even due to trivial causes, it becomes quite difficult to control that bleeding because the blood has become thin due to anticoagulant therapy. Other general causes like liver disease, kidney disease, Other systemic infections like influenza, measles, chickenpox can also result in bleeding from nose. And as I mentioned earlier, idiopathic is also a known cause of epistaxis, which is just a fancy way of saying we don't know the cause. Now, if a patient has presented with active bleeding or bleeding is happening as you examine the patient, then the first thing you need to do is stabilize the patient. You need to stabilize the patient as per ABC principles: airway, breathing, and circulation. Ensure the airway is intact, breathing is happening, and establish intravenous access. Once you have stabilized the patient, you have to stop the bleeding. Of course, the first thing you need to do to stop the bleeding is pinch the nose. Okay, between the thumb and the index finger, pinch the nose for up to 5 minutes. If this does not control the bleeding, then you move to step 2. Pinching of the nose can also be described as Trotter's method, where the patient is asked to bend forwards in front of a basin, keep the nose pinched between the thumb and the index finger, and if any blood is coming to the mouth, patient is encouraged to spit it out. Of course, epistaxis is of two types: anterior epistaxis, which is anterior to the piriform aperture in the nose, and posterior epistaxis, which is posterior to the piriform aperture in the nose. For simplicity's sake, anterior epistaxis is believed to be any bleeding from nose that comes out from the front of the nose, and posterior epistaxis usually goes to the mouth. It can even reach the stomach and come back up with vomit, where it looks like a coffee colored liquid, but it is easily confused with hematemesis, that is vomiting, blood vomiting, or vomiting out blood. But that is not hematemesis. That is actually posterior epistaxis that went to the stomach and came up and got the color changed to coffee colored. So it's very important to distinguish between hematemesis and posterior epistaxis regurgitation. Now, coming back to how you treat a patient with epistaxis, if the nose pinching has not proved to be adequate, the next step is perform endoscopy, preferably endoscopy, but anterior rhinoscopy can also be tried if endoscopy is not available. And if you can identify definite bleeding points, then you can cauterize it. You can cauterize it using chemical cautery, that is silver nitrate, or you can cauterize it with electric current, that may be monopolar diathermy or bipolar diathermy. If electrocauterization or chemical cauterization is not possible, especially in situations where definite bleeding points cannot be identified, there is diffuse bleeding, then the logical step is anterior nasal packing. In modern practice, synthetic materials are available which can be easily inserted in the nasal cavity, and they can be easily inflated to pack the entire nasal cavity, exerting pressure effect and with the help of compression helping in reducing the bleeding. Basically, the bleeding stops because pressure is created which acts on the blood vessels, and this stops the bleeding. In the conventional technique, or if these synthetic materials are not available, then ribbon gauze pack can be taken about 1 meter length, and they can be inserted slowly from front of the nose to the back of the nose. And it's very important to insert it perpendicular, because the roof of the nose may be in this direction, but the floor of the nose is parallel to the hard palate. So if the patient is lying in front of you, this is the direction of the Tilly's forceps in order to reach from the anterior end of the nasal cavity to the posterior end, and of course fill up the floor and then gradually reach the roof. That way we are packing the entire nasal cavity, and again we are creating a compressive action on the blood vessels which will stop the bleeding. If this method also fails, anterior nasal packing also fails, then we move to posterior nasal packing. I'll only describe one method. This is the Foley's catheter method. There are various ways of introducing a posterior nasal pack. The Foley's catheter method is you take a 12 to 14 French Foley's catheter and insert it through the nose. You'll be able to see the other end of the Foley's catheter in the oropharynx, that is behind the uvula. Now you can inflate the balloon of the Foley's catheter, or the bulb of the Foley's catheter, with 5 to 10 milliliter of normal saline. Now the inflated end, the other end of the Foley's catheter is inflated, so you slowly withdraw the other end from the nose. The entire Foley's catheter will not come out because the inflated end will engage in the posterior nasal opening area, or the area of the quana. That way you have packed the posterior nasal opening. Bleeding from the nose cannot go into the throat. But after you have done this, you should also pack the anterior nasal cavity or anterior part of the nasal cavity. That is, anterior nasal packing also has to be done once you have completed posterior nasal packing. If this has also not stopped bleeding, then you have to identify individual arteries or likely arteries and ligate them, starting with sphenopalatine artery. Sphenopalatine artery can be ligated endoscopically by identifying the sphenopalatine foramen by raising the lateral nasal mucosal flap near the posterior end, identifying sphenopalatine foramen and applying a vascular clip on the sphenopalatine artery or by ligating it. If this does not stop the bleeding, we can look at the maxillary artery or the ethmoidal arteries, anterior ethmoidal, posterior ethmoidal arteries, and ligate them. Usually ethmoidal arteries are not responsible for epistaxis, but possible, and they can be ligated quite easily. Maxillary artery is usually ligated by using the Colwell-Lux approach, which is the sublabial approach, finding the posterior wall of the maxillary sinus, and behind the posterior wall of the maxillary sinus lies the maxillary artery, which can be ligated. If this also does not stop the epistaxis, then one needs to ligate the external carotid artery, where in the neck, below or before the first branch. The first branch of external carotid artery is the superior thyroid artery, and external carotid artery needs to be ligated before its first branch. Now, nose receives blood supply from the external carotid system and the internal carotid system. So we can ligate up to the external carotid artery, but we should never ligate the internal carotid artery, because for obvious reasons, if you ligate the internal carotid artery, you are depriving the brain of blood, and it can lead to ischemia in that area of brain, can lead to a cerebrovascular accident or stroke. So if you are ligating arteries to stop epistaxis, you can ligate sphenopalatine artery, maxillary artery, ethmoidal arteries, and external carotid artery, but never internal carotid artery. Even if this has not stopped bleeding, then bleeding can possibly be due to a cause like hereditary hemorrhagic telangiectasia, in which case the nasal mucosa is at fault. This can be treated with laser, KTP laser, argon laser, Nd:YAG laser, and if even laser is not stopping the bleeding, there are recurrent episodes of epistaxis, then the nasal septal mucosa can be replaced with skin by performing a procedure known as septodermoplasty. Some important things that you should ask every patient with epistaxis if you have the opportunity to take history is: what is the onset of the epistaxis? Is it sudden? Is it following a trauma? Is the bleeding from one side of the nose only or from both sides? Typically, if the bleeding is always from one side, say right nasal cavity all the time, then the likely cause is local. You might find a cause in the nose. Also, in local causes, it's not just the nose, it's also nasopharynx. So adenoiditis can be a cause of epistaxis. Juvenile nasopharyngeal angiofibroma can be a cause of epistaxis. The typical presentation in juvenile nasopharyngeal angiofibroma is a teenage male with recurrent episodes of uncontrollable epistaxis, because the abnormal blood vessels that are there in the angiofibroma do not have the contractile layer. So even powerful hemostatic medicines like adrenaline do not have any action in controlling the bleeding in juvenile nasopharyngeal angiofibroma. So coming back to the question you need to ask is the bleeding only from one nasal cavity or from both? Is the bleeding coming out from the mouth or from the front of the nose only? What is the duration of the bleeding? How frequent are the episodes of bleeding? And how much blood do you lose when bleeding occurs? These questions need to be asked. You should also ask the patient if they are taking any blood thinners, any anticoagulant therapy like aspirin, clopidogrel, if the patient has any known bleeding disorders like hemophilia or 1 biliverdin factor deficiency, diseases like that, or the patient has any other chronic ailments like hypertension or kidney disease or liver disease. These questions are very important when you're trying to understand what is causing the epistaxis. Also, some general measures are very important that you should remember while you are treating a patient with bleeding from nose. Like, encourage the patient to sit up even if the patient feels like lying down. Always encourage the patient to sit up with resting their back against a wall, perhaps. Reassure the patient, because anyone with bleeding from the nose will be extremely anxious, but reassurance is not the only thing you should do. You should also find the cause. You should definitely measure the vitals and understand if the patient is in shock or not, because quite possible the patient may have been bleeding for a long time and may have lost a critical volume of blood. So definitely measure the vitals and understand the hemodynamic status of the patient. If you have packed the nose, you should remember that if the nasal pack is there for more than 24 hours, it can act as a nidus for infection. So it is of paramount importance that you prescribe antibiotics, especially if you're anticipating that the pack will remain in the nose for more than 24 hours. Sometimes both nasal cavities need to be packed, sometimes only one nasal cavity needs to be packed. And typically the pack remains there for 24 hours, sometimes for longer duration. Now, if both nasal cavities are packed, due to nasopulmonary reflex, patient may complain of breathing difficulties. So it's a good idea to start moist oxygen therapy. Also, if the nasal cavities are packed, most of the breathing is happening from the mouth. So this can lead to dryness of the throat. So patient might complain that my tongue is becoming dry or my throat is becoming dry, because of course humidification action is only possible through the nose, it is not possible through the mouth. So moist oxygen inhalation is a good idea. So I hope you like this video. You must have got a fair idea about how to deal with a patient who has complaints of epistaxis, either a patient who is bleeding in front of you or a patient who has recurrent episodes of bleeding from nose. So this is the approach to a patient with epistaxis. These are the questions you should ask. This is how you try to manage the patient in a stepwise manner. So I hope you like this video. If you have any questions regarding this topic, I'll be happy to answer them in the comment section. And if you found any mistakes, please don't hesitate to point it out. I will be very, very happy to learn from you. Thank you so much for watching this video. Shout out to Dr. Glaucom Flecken, who is perhaps the best doctor on YouTube. Take care, bye bye, and please don't forget to be awesome.